Yes, sir, we can hear you.
How many participants? 85. Are there any more to join? And yeah, are there any more to join?
I
Because
think
first
it
of all, apologies because there was a bit of a change in the schedule because I had to take one patient who had obstructive jaundice actually to the emergency surgery. So that's why I couldn't do this at 6 p.m. I don't know, due to that fact, anybody will miss this lecture. So that's why I'm a bit worried. So any more to join? If need, I can wait for another 5 minutes. You will decide and let me know.
excuse me, sir.
Yeah. I can't hear. I can't clearly hear
Can
you.
you record this lecture?
If necessary, I can do all of for you later. So, do you think any more? How many are supposed to join? Like, is it 100 or? Hello? Hello?
Normally there are about 110 students. Sir, can you record this lecture and upload it to the?
I will try to do that, but don't worry. I will meet you again in the final year, and I will do you a vote class of this also. If you, I don't know that you all heard from your senior batches, so I'm doing frequently. So don't worry that if necessary, I can even give the slides to you all. That's not a problem. But only thing is, there are certain concepts. Those principles should be registered in your mind today. If that is so, this lecture will be very fruitful for you all. So all your questions are not a problem. We can do everything. Okay.
Okay, sir.
95 are here. Is it okay to start?
Yes, I think we can start.
Okay. So my name is Dr. Deminda Subasing. I am one of the lecturers and consultant gastroenterologist and hepatobiliary surgeons attached to the Department of Surgery. So it's like a common topic from my point of view, and from your point of view also it is very important because you will frequently come across these kind of patients in your surgical clinical practice, and also from the exam point of view that's the most important thing for you all at the moment. So you can get a long case from a patient with surgical jaundice, which is one of the favorite cases, and you can get even short case for abdominal examination, and you can get essays, you can get MCQs, so on, like even best of five, whatever it is. And even in a Viva setting, somebody can question you on any emergencies related to this. So it's a fairly important topic. So in the original lecture schedule, only half an hour was allocated for this and the medical jaundice, but I can take some time more than beyond half an hour, and I can happily help you and answer your questions. So at any point, if you have any questions, I am happy to answer these things, or you can ask the questions at the end. So is that clear outline?
Yes, yes, sir.
Okay, I'm happy if somebody is talking. Otherwise, I feel very bored, and I don't know if these virtual meetings are very artificial, not like face-to-face interaction. So these are the objectives for the next half an hour. So basically, you need to understand the surgical anatomy related to the extrahepatic biliary tree and the liver. And I know the pathophysiology of this physiology of bilirubin metabolism and these kind of things have been dealt with early lectures in the gastrointestinal system module. Am I correct?
Yes, sir.
Right. So definition of the jaundice, then how do you classify, then how do you come into a diagnosis, treatment, and important points in the history and examination. And there are like certain specific investigations apart from the common investigations are being to be dealt with the biliary tract, and how do you treat these kind of patients. If you go through this, so you will cover the whole topic. So let's start with basic anatomy. I'm not going into very much details, but everybody should know, have a basic idea of this diagram. Now, if you look at this liver, it has like a tubing system inside it, although you can't see it, which is called biliary tree. So this is like a root of the tree. So ultimately you get like two main ducts coming out of the liver hilum, the left hepatic duct, this one, and the right hepatic duct. And this area is called the confluence, where your left and right hepatic ducts unite together. And your gallbladder is here and the cystic duct is here, and this area is called common hepatic duct. And once the cystic duct joins, it forms the common bile duct, and it joins this pancreatic duct after going through the pancreatic behind the pancreas, and which will open in a common channel which is called ampulla into the second part of the duodenum. So you need to have a thorough idea and understanding to deal with the patient with obstructive jaundice. So obstructive jaundice, as you mentioned, is surgical jaundice. Basically, any kind of obstruction along these pathways I mentioned, which can give rise to a obstructive jaundice. So let's go on. So this is again very boring. You know, this jaundice is defined as yellowish pigmentation of skin and the conjunctival membranes due to the hyperbilirubinemia, the direct hyperbilirubinemia in surgical jaundice. So these are the cutoff values. You are almost familiar with these kind of values, but again in your physiology lectures, just remember the values. These things might pop up in your MCQ paper. So basically, surgical jaundice could be defined as any jaundice which is amenable for surgical or endoscopic treatment. So major causes are due to the, as I mentioned, due to the obstruction of the extrahepatic biliary tree. Jaundice, again, remember, it's not a diagnosis, it's a presentation. So underlying diagnosis you have to find out by history taking, by doing a proper thorough examination and doing the relevant investigation, which includes imaging and other endoscopic ones apart from the biochemical investigation. So again, this is like a bit of a slide which summarizes the bilirubin metabolism. Now, in my point of view, in the surgical point of view, the basic problem with the obstructive jaundice is the bile is not flowing to the intestines. Now, bile which flows to the intestine, which will form bile acids, bile pigments, which will normally give the color of your stools. And you know, in the bile acids, there is an intrahepatic circulation. So all these things will be disrupted when you have obstruction to the biliary tree, extrahepatic biliary tree, which is the surgical jaundice. So there are various manifestations we can explain by, if you remember, the underlying mechanism, because you know the bile salts are important. You know this factor 2, 7, 9, 10, protein C, protein S, which are like vitamin K dependent factors. So everything get disrupted. So all these things, when you get a patient, you need to apply this knowledge to the patient to find out what's going on with the patient, who index patient who's having surgical jaundice. So these are the normal bilirubin values, total and the directs, and micromole per liter as well as milligram per deciliter. If you look at the hospital reports, even in our hospital, sometimes you get reports from either value. So just be familiarized with this, but you don't have to by heart. But it's nice to have like a overview of these values also, because again, you know, the MCQs and things can be asked. Now, post-hepatic jaundice is the area of discussion of the today's lecture, which is called obstructive or surgical jaundice. And the pre-hepatic, hepatic, these will be discussed with you in the medical jaundice part in that particular lecture. So any cause which can cause the obstruction to the main bile duct, which can give rise to a direct bilirubin level in the urine. Now, as I mentioned in the early slide, the bile is not flowing, so you get like a clay color stool. So, and your direct bilirubin level is high, your mucosas become pigmented. Therefore, your body membranes will become yellowish color. So the four cardinal features are like icterus, then your pruritus, and you get dark color urine, and then you can get clay colors too. So those are the main features even in your own history taking to clarify with the patient. Bit of a busy slide. Again, the important thing here is that obstruction can happen at various levels. There could be many etiological factors for the obstruction. So that, of course, you need to keep in your mind. Now, extrahepatic biliary obstruction, which is mainly occur due to the secondary to the external, due to the compression. Like if you get like a benign cause, the common cause is the gallstones. Now, when coming to the gallstones, again, you need to know about the like a type of the gallstones. Gallstones could be primary or secondary. Now, most of the time, it's secondary gallstones, which are originally originated from the gallbladder. Then, with your biliary colics, they migrate into your biliary tract and will give rise to obstruction of the common bile. Now, even after cholecystectomy or the laparoscopic cholecystectomy, which is the gold standard of the treatment of gallstones, you can still develop stones within your common bile duct due to the stasis, due to the various factors like strictures, which are called like primary stones. Okay. Then the blockage can happen due to infection, malignancy, and various other causes as well. Now, external compression, which can happen due to like inflammatory causes like in acute pancreatitis and various like pancreatic malignancies. Again, your distal CBD can get externally compressed, infiltrated. So whatever can cause conjugated hyperbilirubinemia. So as I mentioned earlier, this pruritus can happen, but in some patient you will not get pruritus. Very strange. There's no explanation for that. Even in if you come to the clinicals, you might see this some of these phenomena, right? So if I summarize what I said with regard to the causes of the obstructive jaundice, in a clinical point of view, in a more practical point of view, rather than going through the book descriptions, it could be benign, it could be malignant, it could be painful, it could be painless. So painful surgical jaundice versus painless jaundice will divide your differential diagnosis into broader groups. Like usually, if you have pain preceding abdominal pain, like biliary colics, it will point to like a painful jaundice, and your etiology most probably could be a common thing like gallstones. But the painless ones also can happen, which are more sinister causes, malignant causes like periemperor disease. You know about periemperor disease? It's a cancer which can arise about 2.2 centimeter radius around your ampulla, as I mentioned in the previous diagram, which includes three malignancies like your pancreatic head, your distal CBD, or your duodenum or the ampullar area. And if I go back to the first slide, this diagram, you can see this extrahepatic biliary tree. So your cholangiocarcinoma can occur at any point of this along this tubing. It could be like distal CBD cholangiocarcinoma. It can happen here like a mid CBD cholangiocarcinoma. So it can happen in the confluence, which is called Klatskin tumor, or the perihilar cholangiocarcinoma. And sometimes your gallbladder can transform into a malignancy, which can infiltrate in this area, again can result in biliary obstruction. So depending on the location, your physical signs might vary. So we'll come into that later. Now I'm going back to the previous slide again. So these are the like common causes, and other thing is your like extrinsic compression. Sorry about this. This is due to malignant lymph node in the porta hepatis. If you look at the benign causes, apart from the commonest one, this choledocholytitis, which are the CBD stones, your chronic pancreatitis, which can result in long-term repeated acute inflammation which leads to chronic inflammation, which can cause stricture formation in the distal CBD. And one of the common surgeries performed during this era is laparoscopic cholecystectomy, which is a major problem which associated with the cholecystectomies, post-surgical biliary duct bile duct strictures, which are called iatrogenic bile duct injury. So even after trauma, it can happen, and this primary sclerosing cholangitis is like a medical disease, but still can give rise to like extrahepatic biliary strictures. So it's like a partly surgical. These things, although the strictures can happen inside the liver, but again in the distal CBD strictures can result from due to underlying primary sclerosing cholangitis. So you need to have all this basic information when you are dealing with the patient. Now, again, if you are going into like rare causes, you have to remember these things like there are various parasitic infestations like Ascaris lumbricoides. There are liver flukes which are called fasciola hepatica if you do remember your parasitology. So these are like rare causes which we see most in the like Western countries. One other thing I specifically made this slide because this is one of the important and very interesting phenomenon of this Mirici syndrome. It's related to the gallstones where your stone is impacted in your neck and the Hartmann pouch of the gallbladder, which can exert external compression on your bile ducts. So there are various types of Mirici syndromes, but those are beyond your level. So there are like 5 types. Type 5 is gallstone ileus. So I don't think you need to go into that extent. So you need to have a basic idea what is Mirici syndrome and what will happen. Like it's like external compression of the biliary tree, which can give rise to obstructive jaundice. So as a clinician, if you have this background knowledge, what is more important thing is when you come to your professorials, when you become like an intern house officer in surgery, or some of you all will do surgery in the future. So it's more relevant then. So whatever the setting, you need to be more practical person now. If you have a clinical knowledge, you need to apply to a patient when you have a patient in front of you. Like you need to get a adequate history in examination, investigation, and treatment. That includes the clinical evaluation. Again, when you come to the final year, you need to practice a lot. You have like 20 minutes to get this history. Sometimes you might have another 10 minutes to get like observed examination, observed history taking an examination. Then you have a discussion of another 20 minutes. So you need to practice to do all these things, apply this knowledge, and take a history and relevant examination from a jaundice patient. But the previous knowledge which I mentioned in the previous slide are much more helpful to do that task. So if you get a patient with a obstructive jaundice, you must first confirm what are the features she is having. Whether you have like dark color urine, pruritus, yellowish discoloration, and the pales too. So that itself will point towards the listener that this person is dealing with like a obstructive jaundice patient. Then again, the age of the patient is important. We always ask the age at the end because elderly will get like most of the like all the most cancers can happen with the age. That doesn't mean a young patient will not develop cancers, but towards the aging process, the cancer is more common. So age is important. Then the duration, onset, progression, everything is important. Like for an example, most of these malignancies associated with anorexia and weight loss. But again, you need to ask when the jaundice appear, when this anorexia and weight loss appear. Now, for an example, if you get a cancer within your bile duct like cholangiocarcinoma, you will get obstruction of the bile duct first. So your jaundice will appear more early. Then when it progresses, it can metastasize and then can give rise to like a anorexia. But in contrast, if you get like a pancreatic malignancy, anorexia is early feature. Then once the pancreatic cancer is infiltrated into your bile ducts, then you get obstruction. So you need to very importantly analyze what is the onset, what is the progression of these associated symptoms as well. So I have briefly mentioned again like in a nutshell, so what are the things you need to ask. This is very mechanical, but you should when you are practicing, you should have like these kind of notes. So whether it's painful or painless, the systemic symptoms, like for an example, fever, it's important thing to ask. Now, again, in a history taking, we will realize when you come to the final year, I know most of your colleagues has realized who are doing the employment with us at the moment. So, why you are taking history? Can I ask a question from you all? So, why you are taking history from a patient? Let's talk. Otherwise, I'm not listening from you all. Why we are taking histories? Anyone? Are you all with me? Hello?
Patient's history can give us clues to the diagnosis of the patient's disease.
Yeah, exactly. To the main idea of the taking history is to come into a diagnosis or the differential diagnosis. Because every time you can't come into a definitive diagnosis by the history. In that case, you can narrow down your differential diagnosis. Other thing is, it's not just to find out the diagnosis or differential diagnosis. If you find a diagnosis, you need to find the anatomical diagnosis, you need to find the pathological diagnosis, you need to find the etiological diagnosis, you need to find the complications, and you need to find out what has happened up to now in the index admission. So that's why we are taking a history. That's why it's an important skill. I know most of you will realize importance of history taking when you come into the final year, because I have deal with the final year students, so I know how they are doing. So this is just a guide for you all. So painless versus painful is an important thing to ask. Then anorexia and weight loss important to ask. And other thing is, so if I ask some of you, what are the complications of obstructive jaundice? Can somebody quickly answer to that? Yeah. Udari? That's the only name I know here. Hello? So what are the complications of obstructive jaundice? Do you know? So I will mention. So you can, your main problem is your bile is not flowing into the intestine. So you can get like various like vitamin K dependent factor deficiencies, and that's one thing. Now there are two things. One thing is your bile duct get obstructed and your bile is not flowing into the intestine. So let's think in that line. So bile duct is obstructed. You have a system which is obstructed, which can get infected. So that is called cholangitis. When your obstructed bile duct can get infected with bacteria, so you can get cholangitis. So cholangitis, if you get cholangitis, you can get fever, again pain and chills. So that's called Charcot's trial. And other thing is your bile is not flowing, therefore there is like a vitamin K deficiency, so you can get bleeding tendency. That's one thing. Other thing is even these tumors, they can bleed. Another thing is you can get low urine output due to your hepatorenal syndrome. So these are like there are various types of hepatorenal syndromes, but important thing is to ask about the urine output, bleeding tendency, whether the patient had any features of cholangitis. So all these things you need to find out under the complication tab. Okay. Then coming into the exam now, you know the past medical history, past surgical history, your family history, your all these things can be asked. But the important thing is to get the presenting complaint of jaundice and to analyze the presenting and the associated symptoms. And if he is a smoker, you can take that part upwards, because smoking is a risk factor for like biliary tract cancers, as you already aware from the other lectures. So I have in this slide, I have included some important and interesting physical signs. So if you look at here, so you need to look for the jaundice. You need to look at the sclera. But again, if the patient is pale, it's difficult to assess by looking at the conjunctiva, because your membrane is already pigmented. So It's like a difficult physical sign to elicit, but you need to always look at the tongue of the patient, palm of the patient, as well as the conjunctiva. Then with biliary and upper gastrointestinal tract malignancies, you can get a Virchow's node, which is called Trousier's sign. So in between your two heads of left side sternocleidomastoid muscle, your left supraclavicular lymph node enlargement, if you examine, you will find that. Another sign of very advanced malignancy is this Sister Joseph's or the umbilical nodule. That's also another thing. And more importantly, in abdominal examination, you need to look for a palpable gallbladder, because a palpable gallbladder will divide your diagnosis broadly into two parts. Now, if I go back to my first diagram, now the gallbladder to be palpable, your cystic duct should get obstructed. You should have obstruction here or the distally. Then only your gallbladder become palpable. Now, if you have a cancer here like hyalopharyngeocarcinoma confined to this area, your gallbladder is not going to be obstructed. Then your gallbladder is not palpable. Therefore, if you have a palpable gallbladder, it's most likely to be a obstruction beyond the cystic duct insertion point. So this is very easy. These are not actually surgery. These are very logics, right? So palpable gallbladder is an important sign. Then you can look for enlarged liver, you can look for a free fluids, other kind of thing. And as with any malignancy, you can get a DVT, you have to look at the calf, and as well as like in pancreatic cancers, you get a thing called migratory thrombophlebitis. So that's another important sign. So these things you must have core knowledge, because these are very interesting. Another thing is these things can question from pure MCQs. Okay. So these are the things I have mentioned, and everybody knows, I think, about the Courtier's law. That means in a patient with obstructive jaundice, if your gallbladder is palpable, it's most likely to be due to like malignant cause around the periampullary, but there are certain exceptions also. So you need to read around that. So the next part after history taking examination is to do a targeted investigation. Now, if you have a suspicion of jaundice, you can ask for a liver function test to look at the direct and indirect fraction, total fraction of the bilirubin, and then by you have to confirm your obstructive jaundice. Then again, these clotting studies are very important, because clotting can be deranged due to the facts I explained earlier. So I omit that slide. That's not much of a helpful slide. And then there are various investigations which are specific to the biliary tract. So I will go on, like you can do like if you are suspecting malignancy. Again, if you are doing investigation, you need to confirm the diagnosis. So that's why we did bilirubin and things. Then the ultrasound scan is a very basic investigation. So you need that by doing ultrasound scan, you look for a dilated extrahepatic biliary tree. That's the most important thing in a surgical jaundice. Then you need to find the cause, like you need to do imaging to find out any masses in relation to the pancreatic head and biliary tree area. Then there are various like endoscopic tests as well as. So ultrasound again is the baseline investigation. You all need to remember about that. This is trans-abdominal ultrasound scan. This is a very basic thing. Then your next line of investigation is CT scans, which is triphasic or contrast enhanced CT scan of the abdomen and pelvis. Again, we can do like pancreatic protocol CTs if you are suspecting like a pancreatic head malignancy. So this is to like stage the disease. First you confirm your jaundice, then you find the disease, then you have to stage the disease if you are suspecting a malignancy. And I hope everybody has heard about this ERCP, which is endoscopic retrograde cholangiopancreatography, one of the invasive investigations, endoscopic investigations in relation to the bile duct and the pancreatic duct system. So you can see on your left hand side of the screen, this area, this arrow, you can see that there's a mass here, and then this is the bile duct. Your bile duct is dilated, and this is your pancreatic duct, which is also dilated. So this is called double duct sign, which is very much diagnostic of a periampullary malignancy. And your this black color thing and this white color thing is your endoscope, ERCP scope. So this is how you are. Now, if somebody asks, what is this investigation? You have to look at. You can see the bile duct, you can see the pancreatic duct, and you can see the endoscope. So this is ERCP, not MRCP. So that's one thing you need to keep in your mind. And apart from the ultrasound, which I mentioned, this is a trans-abdominal ultrasound, there's another endoscopic modality which is called endoscopic ultrasound, where you do endoscope. At the end of the tip of the endoscope, there's a ultrasonic probe where you can go into the posterior wall of the stomach, and your pancreas and the bile duct, these are behind the posterior to the stomach and the duodenum. You can access from the stomach and duodenum, and you can see your all other structures, and this is not only diagnosis, it's therapeutic as well. So for the diagnosis, you can do various sort of FNAs from this. So just to bear in mind, there is a kind of investigation called endoscopic ultrasound, but you don't need to know about very hi-fi stuff. You need to know it's diagnostic as well as you can do therapeutic interventions from that. Then the other non-invasive but fascinating thing is your magnetic resonance cholangiopancreatography, which is called MRCP, which is only diagnostic. It is not therapeutic, but it's very sensitive one to help to detect to map the biliary and pancreatic duct, especially if you have strictures, tumors, and masses, you can see that. So all these things are mentioned in your Bailey and Love, so you need to look into that also, right? So how do you treat these patients? So you need to take care of these patients, especially these kind of jaundice, surgically jaundice patients are very ill patients because they are anorexic, their bile duct is obstructed, they can get septic. So depending on that, you need to intervene. Now, one of the most important concept is these patients can become quickly dehydrated, and because they can't eat and drink, so we can go into renal failure. So adequate hydration is one of the important concepts. Another thing is, other complication is you can get cholangitis. So if you get cholangitis, you need to suspect then and there, and you need to send blood culture, you need to send your plottings, and you need to prepare your patient for a drainage, which is done via endoscopic retrograde cholangiopancreatography. So again, for the pruritus, you can give us deoxycholic acid, and if there are any gallstones, you can. We'll go on with the further slides. You can definitive treatment is removal of your gallbladder or the CBD exploration in case if necessary. And again, it's a good idea to correct the coagulation by giving vitamin K, and you can use the FFP for the correction of the hypercoagulability. Yeah, these are the things I have mentioned up to now. So yeah, all this mentioned. And again, if you need to monitor the urine output, you need to put a catheter even before the surgery, and you need to keep the patients well hydrated. And even after surgery, these patients need to be under very thorough monitoring with regard to the urine output and other things with fluid resuscitation. So surgery is very simple. Now, if you have surgery, it depends on the cause you find in the patient. Now, for an example, if the patient is having symptomatic gallstone, which leads to bile duct stone, so you need to find the cause and treat the cause. So the goals and treatment for the symptomatic gallstone are laparoscopic cholecystectomy, and if there's a blockage of CBD, you can deal with CBD exploration, or you can go for a preoperatively removal of stones by ERCP. Then the definitive treatment again after the ERCP, you can go for a laparoscopic cholecystectomy. So that's the very basic procedure, very common procedure, which is happening in every part of the world. Now, as I mentioned, it's according to the cause. You can do ERCP. So this is the one of the. If you see this diagram, you can see there's a big stone at the ampulla. This is the ERCP, the cannula. So this is how you remove the stone before the laparoscopic cholecystectomy. There are various ways to remove the stones, like putting a balloon and pulling it down, or putting a snare and catching it down. So various things, right? Yes. So these are the just pictures found during intraoperative. So this is your gallbladder on your here, and this is your laparoscopic cholecystectomy, and this is one of the open surgeries. This is your bile duct, and this is a small incision over the bile duct, and we are removing the stones in the common bile duct, which is called open common bile duct exploration. Then other major thing is your carcinoma of the head of the pancreas or the periamperic cancers. So these are very complex malignancies which needs like very complex procedures like classic Viper's pancreatic duodenectomy. You should have a basic idea which part are being removed after a Viper's operation. Your distal stomach, as I mentioned, this is a reconstruction which is done after the surgery. You're part of the stomach, you're part of the pancreatic head, and your part of the bile duct is removed, and this is the reconstruction with pancreatic or jejunostomy here, and the bile duct and jejunum hepatic or jejunostomy, and to restore the biliary, restore the enteric continuity, the gastrojejunostomy, right? Not a high-fi stuff, just to have a idea, right? And these tumors sometimes not resectable. In that case, you need to palliate these patients by doing like bypass. And nowadays, surgery is very much less role in palliation because you have endoscopic facilities. You can do a ERCP and metal stent to the bile duct to relieve the bile duct obstruction, and we can refer the patient to oncologist for adjuvant chemotherapy. Again, it's flat skin tumor, as I mentioned, which is high-level you need to get a remove it with the part of the liver. Because we need to remove the cancer completely, so you need to remove the part of the liver as well as the bile ducts, and to reconstruct with which is called hepatico-jejunostomy. Hepatico means your bile duct, and jejunostomy means your jejunum is loop of the jejunum is used to reconstruct. Again, biliary strictures, again you can do this biliary bypasses. So this is the cut end of the bile duct here. Don't worry about this diagram, this is just to generate some interest among yourself. And this is your loop of the jejunum. This is after the surgery you do the anastomosis. I'm sure the pediatric biliary atresia, which has been dealt in an earlier lecture, and when you do the pediatric referment, you will get to know about this Kasai's operation, which is beyond the discussion of this level. The chronic pancreatitis, again, which can cause strictures, which can be treated with endoscopic retrograde cholangiopancreatography with the insertion of a stent or a sphincterotomy. Yeah, I mentioned about these complications also. Yeah, so that's it. I think I took about 45 minutes. So I'm happy to answer any questions if you have anything, any comments, any questions, any areas of cloudiness or anything you want to clarify, you can ask. Anybody can ask questions. There are no silly questions, there are no great questions. Every question is a question. So I'm happy if anybody can ask any question. Yeah. Hope you all are not already fallen asleep. Hello?
Yes, sir, we can hear you.
Can you hear me?
Yes.
Yeah. Any questions? I am happy to ask. Any areas of difficulties? Let's deal now. That's why I told every question is a question, important question. There are no silly questions. Sometimes people won't ask questions, think that others are listening, others might think I'm asking a silly question. There's nothing like that. People who have asked questions will learn. I can see slowly the numbers going down. The 94 is now. Earlier they have 102. Yeah. Yes, there is. I'm asking if somebody can to quickly like switch on the mic and ask the question. So, but I'll answer to this. So, our question is this out of this is out of the lecture, right? What is the prognosis if damage portal vein during the bypass surgery? Very important question. Uh, it doesn't has any implication on your prognosis. If your portal vein is damaged, you need to repair it. But all these surgeries are done in like a which are called high volume centers. There are things like high volume centers. There are certain centers which will do these kind of surgeries frequently. Like so, in that case, the surgeons are very familiar with this. They can directly deal with without having much blood loss. So there, in terms of disease, there's nothing implicated with regard to the prognosis. But if you can't repair it quickly, if you don't have the expertise to do that, then the patient will can die. That's a different story. So I think I have answered to that question. Then the second question is from Kasturiya. Yes. Can hepatic encephalopathy be occurred as a complication of obstructive jaundice? Yes, with obstructive jaundice, you can get like congestion. So with any chronic liver disease, you can get hepatic encephalopathy, but it's mainly with the chronic liver disease like cirrhotic kind of thing. It's more common in under the background of chronic liver disease, but there is a rationale of asking this question. It can, because your bile duct is obstructed, your liver is congested, so you have a very like congested liver. Yeah, it can happen. I'm happy to hear some voices rather than texting me, but if you are not comfortable to ask, I don't mind texting. When you all are doing your professorials, when you all are supposed to do?
We are still in the third year, sir.
You all are third year, so but you will meet me in another 2 years. So these things will be more practically discussed when we meet in our boards. So don't worry about that. So by one lecture, you can't sometimes grab everything. There are different kind of learners. Somebody can read the books and understand their own. Somebody can just grab everything by a lecture. But most of people will not understand lecture, but they will go and read and catch up at various stages. But when you come into the final year, it will not make a difference because for everything there's a learning curve. There are quick learners as well as slow learners. Yeah, any other question? So in the absence of any questions, if there are no questions, I'm happy to conclude. But I would be grateful to you. I think Udari has my email address. I would happy to get a feedback on this lecture because I need to uh, personally document those things, and it will be helpful for the future students as well. So I would kindly request you to send a feedback, and I will send my email here. Any questions? I'm happy to answer till I type this.
Excuse me, sir. What is hepatorenal syndrome?
Yes, hepatorenal syndrome is when you have like a bile duct obstruction because of the liver is congested. Secondary to liver disease, you can get a renal failure. It's like a kind of like a there are various types, type 1 to type 4. So if I go into the hepatorenal syndrome itself, a lecture if I'm doing, so you need to read around that and understand there are various types, type 1 to type 4. So there are various diagnostic criteria, there are international criteria, but at your level as a final year or third year students and person who is going to a house officer, it's like kind of a renal failure which happens with the background liver disease, which can happen in a patient with obstructive jaundice. And the important thing is not to keep this patient underhydrated, underfed. So you need to treat with IV fluids to prevent this. And again, you need to make sure not to do any insult like doing contrast CTs. So if you are doing contrast CT, you need to very very good hydration is necessary, right? There are some more questions I can see. Let's answer this question first. The why cholecystectomy is considered as a gold standard in symptomatic goals? Because it's like, I don't know if I say, like, you know, the Hetupalawade. If something to happen, there should be a reason. You should abolish this reason. So you go, most of the goals also originating in the your gallbladder. Then they will fill and they will migrate and they will cause the problems. So symptoms originate from mostly from the gallbladder. Therefore, removal of gallbladder, the cholecystectomy is considered as gold stand, and laparoscopic cholecystectomy is considered as the gold stand treatment of the symptomatic gallstones, because now everything is laparoscopic, not like 20 years back. It's open cholecystectomy 20 years back, now it's laparoscopic cholecystectomy. So that question's also dealt with. Yes. Anything else? Somebody was going to ask something. Yeah. So this is my email address. Anything else? So shall we conclude then? Are you all happy? Udari?
Yes.
Shall we conclude then?
Okay.
Okay, thank you very much for listening, and thanks for bearing with me, because with my busy schedule I had to go to the theater, so therefore I had to change the time. And thank you very much. If you have any questions, if you can't ask me, you have my email address. You can just drop emails, whatever it is. Okay. Thank you very much. Then have a nice evening. Okay.
Thank you, sir.
You're welcome.